Welcome to the lecture for Chapter 15, Feeding and Swallowing Disorders. We're going to be talking about dysphagia, which is a swallowing disorder. An individual exhibits an unsafe or inefficient swallowing pattern that undermines the eating or drinking process. This can occur at any time, but most likely will occur among infants and the elderly. Dysphagia, some of the terms we'll talk about include deglutition, the complex neuromuscular act of moving substances from the oral cavity to the esophagus. And the substance that's being moved from the oral cavity to the esophagus is referred to as the bolus. Penetration, food or liquid enters the larynx, which can cause choking and respiratory distress. An aspiration, where the food or liquid passes through the larynx and into the lungs, which can cause asphyxiation or a pulmonary infection, such as pneumonia. You may have heard of a silent aspiration, and with that, there's no sign such as choking or coughing or speaking with a wet or gurgly voice to suggest that aspiration is occurring. And that can be kind of a scary time for families, and you as a speech language pathologist can help families to be able to recognize when that might be occurring. First, we're going to look at the normal swallow and what stages or phases accompany a normal swallow, and those are the oral preparatory phase, the oral phase, the pharyngeal phase, and the esophageal phase. In the oral preparatory phase, you're going to be preparing the substance to be swallowed for swallowing. And the food or liquid is going to enter the mouth, and the material in the oral cavity is going to be contained by closing the lips, manipulating and preparing the food or liquid into a cohesive ball or bolus. In the oral phase, the intention is to move the bolus to the rear of the oral cavity and prepare it for propulsion down the throat. And this begins as the tongue propels the bolus to the back of the mouth. In the pharyngeal phase, you're going to be propelling the bolus downward through the throat to the entrance of the esophagus. At the start of this phase, the pharyngeal swallow reflex is triggered. The posterior pharyngeal wall and the back of the tongue are going to create pressure that moves the bolus downward through the pharynx. During the esophageal phase, the bolus is going to be moving through the esophagus into the stomach, and the bolus passes through the upper esophageal sphincter, is propelled through the esophagus by an involuntary wave or contraction, and then passes through the lower esophageal sphincter into the stomach. Obviously, breaking down the swallow into these different phases makes us look at all of the intricate parts that have to be working together to make the swallow effective. I tend to take it for granted that I just swallow. When I put a piece of food in my mouth, I'm just going to swallow it down. Breaking it into these phases or stages really makes us think about all of the things that need to be incorporated when we have even one swallow to occur. The esophageal phase ranges from about 8 to 20 seconds for adults, and the movement slows as we age. This is referred to as a decrease in esophageal motility. And now we're going to look at the disordered swallow, which is referred to as dysphagia. Dysphagia occurs when an individual exhibits difficulty in at least one of the phases of the swallow, causing swallowing to be inefficient or unsafe. And it's important to note that dysphagia is not a disease, but rather it's a symptom of an underlying cause. Swallowing problems can result from neurological injuries, progressive disease processes, head and neck cancers, or even sometimes the medical treatments prescribed to combat a disease, such as radiation to treat laryngeal cancer. When swallowing is inefficient, it doesn't provide adequate nutrition. And when swallowing is unsafe, individuals are at risk of penetration or aspiration because of poor coordination or management of the bolus as it moves through the swallowing phases. And like I said previously, you can imagine this might be quite traumatic for obviously the person it's happening to, but also to family members who may need assistance in being able to recognize when swallowing has become unsafe for a family member. Okay, we'll look at pediatric feeding disorders first, and then we'll look at those in adults. So a feeding disorder, a child's persistent failure to eat adequately for a period of at least 1 month, which results in a significant loss of weight or a failure to gain weight. A child also displays one or more of the following: an unsafe or inefficient swallowing pattern, a growth delay affecting height and or weight, lack of tolerance of food textures and tastes, and poor appetite regulation. And characteristics of pediatric feeding and swallowing disorders are that they are unsafe, inadequate, and inappropriate. And we'll look at each one of those a little bit more closely. Unsafe feeding and swallowing typically results from the dysfunction of or damage to a child's oral motor system or an inappropriate eating rate, either too fast or too slow. Swallowing dysfunction can affect planning, timing, coordination, organization, and sensation. You may recall maybe from your own childhood, your mom or your dad, an adult in your life who is eating with you, telling you to slow down or don't eat so fast, don't put so much food in your mouth, take small bites, and those were all for a good reason, so that you could be safe while you were swallowing. Causes and risk factors. Dysphagia frequently accompanies a number of syndromes, particularly those that feature low muscle tone, which is known as hypotonia, delayed motor development, and physical deformities affecting the oral motor area. Children with Down syndrome may exhibit hypotonia, contributing to a weak suck, which can result in a swallowing impairment. Cerebral palsy also presents a significant risk factor for dysphagia. I have children currently on my caseload who have both Down syndrome and cerebral palsy, and feeding and swallowing are definitely issues across the board for children with Down syndrome and cerebral palsy, at least in my experience, whether it's a weak suck or just resulting from the low muscle tone that they experience. Low birth weight, developmental disabilities, prematurity, prenatal drug exposure, and diet restrictions contribute to the causes and risk factors. Then looking at inadequate feeding and swallowing, inefficiency, over-selectivity, refusal, and feeding delay. And looking at inappropriate feeding and swallowing, children who exhibit inappropriate feeding behaviors demonstrate undesirable and disruptive behaviors during meal times. If the inappropriate behaviors are significant, the children's growth and development may be compromised as successful feeding is disrupted, turning mealtime interactions into serious and stressful struggles between caregivers and children. Inappropriate feeding behaviors include screaming, spitting, throwing, hitting, and other similar actions. And you could definitely see how these might contribute to children having unsuccessful feeding experiences. Let me go back to this slide for just a minute, looking at it a little bit more in depth. Efficiency, who are inefficient at feeding and swallowing, they will be unable to meet their caloric and nutritional needs because the process is not productive. During feeding, inefficient feeders may tire easily, become breathless, or show a lack of persistence. And these characteristics can contribute to undernutrition and growth delays. Looking at over-selectivity, some children eat too little because of moderate to extreme over-selectivity. They're picky about the taste, type, texture, or food volume that they're going to eat. They may reject all members of a particular food group because of the taste or type, such as all vegetables or all green foods, for example. Looking at refusal, some cases of pediatric undernutrition result from a complete refusal to eat. Most young children will periodically resist foods for one reason or another, but an ongoing refusal to eat is a more serious matter that can occur for several reasons. The child might have a physical or medical issue that hasn't been resolved. They may have poor appetite regulation because of constipation, refusing food on the days where he or she has not had a bowel movement. They may have gastrointestinal issues such as reflux. Gastric acid is regurgitated into the esophagus and even the pharynx, resulting in a burning of the esophagus and throat. So as you can imagine, it's not going to be desirable for a child to put food into his mouth and swallow it if the reflux is occurring. Children may have experienced a traumatic event that results in resistance to eating. This is described as conditioned dysphagia. Some children resist eating after experiences with choking or ingesting a poison or having a severe allergic reaction. And then lastly, looking at feeding delay. Because of developmental delays, illnesses, or trauma, some children experience delayed development of feeding skills. And these children are slow to meet major milestones, transitioning from a bottle to a cup or finger feeding. Major milestones correspond to increasing nutritional needs, such as transition to table foods, provide greater nutritional variety to support growth and development. So when children do not make these transitions, their delays may contribute to inadequate feeding. Causes and risk factors: being overactive and overstimulating, being underactive, passive, and unengaged, being rigid, directive, and demanding, chaotic, disorganized, and frenzied, overly concerned, anxious, and fearful. And looking at these causes and risk factors, you can see how these might contribute to having negative feeding experiences. Early identification and referral. So the timely identification of pediatric feeding and swallowing disorders is critical so that immediate intervention can sustain the child's health and nutrition. Newborns stay in the hospital typically for 48 to 72 hours, but obviously will stay longer when complications are evident or when the child is underweight or premature. Looking at comprehensive assessment, a speech-language pathologist will conduct a comprehensive assessment that includes a case history, a physical feeding and swallowing evaluation, and observation of mealtime interactions. In looking at the case history, to the SLP about the child's and family's eating and feeding experiences, which then can be used to explore possible problems, looking at changes in behaviors over time and documenting specific manifestations of the disorder. Parental report on the length of meals, quality of intake, and a child's progression from breast or bottle to purees and solids are going to help to identify where any breakdowns might have occurred. And looking at a physical feeding and swallowing evaluation. After a case history is taken, the SLP is going to complete an evaluation of the structures and functions of the child's oral motor mechanism. Let me skip ahead over here to this. So an observation of the lips, tongue, jaw, teeth, and hard and soft palates will occur. And a structural exam is going to study the physical nature of these structures and will also assess how they work together during eating and swallowing. The structures and functions at rest will be examined, and also during feeding. Then treatment goals in pediatric feeding and swallowing to ensure that nutritional needs are met for healthy growth and development and that feeding and swallowing do not endanger a child's life. This can mean providing an alternative or supplemental nutrition via tube feeding. Once those immediate goals are achieved, focus on improving a child's own ability to meet her nutritional needs and to see eating as a psychologically pleasant experience. Going back to in the middle where it talked about alternative or supplemental nutrition via feeding tube or tube feeding, this can be done through a nasogastric tube or through also a G-tube or gastrostomy tube. And those are two different types of tubes that can be used as alternatives to feeding. Alternative and supplemental feedings. Also children who are unable to meet their own nutritional needs orally and whose growth is faltering require alternative solutions. Children who are candidates for this are those who cannot meet 80% of their caloric needs orally, those who have not gained weight or who have continuously lost weight for 3 months, those whose weight and height ratio is below the 5th percentile, and those whose feeding time is greater than 5 to 6 hours daily. And moving on to defining characteristics of adult dysphagia. The phase of swallow affected, the underlying pathology or cause, and the severity of this disorder are all things that are going to be defining characteristics. So the phase affected refers to dysphagia being characterized by the phase affected to identify the site at which the swallowing system breaks down. The SLP is primarily concerned with disorders in the oral preparatory phase, the oral phase, and the pharyngeal phase. In the oral preparatory phase, decreased lip closure will be present, resulting in problems in taking foods or liquids from an eating utensil, straw, or cup, and allowing food materials to leak from the mouth. Obviously, if you can't obtain lip closure, it's going to be very difficult to keep that food or drink from leaking. Problems controlling ingested materials such that food or liquid falls in the space between the teeth and gums. And then difficulty biting or chewing, which will be hindering the formation of a bolus. In the oral preparatory phase, reduced range of motion of the tongue and or weakness of the tongue, requiring increased time to prepare the bolus for swallowing, and impaired sensitivity of the tongue, lips, and other oral structures that hinders food positioning and management. And then in the oral phase, difficulty moving the bolus to the pharynx, resulting in food or liquid residuals remaining in the mouth, will be present, along with inability to adequately control the bolus flow, such that some materials spill into the pharyngeal region prematurely. And then delayed initiation of the bolus movement, increasing the transit time from the oral to the pharyngeal phase. Looking at the pharyngeal phase, incomplete palatal elevation to seal off the nose from the pharynx, allowing foods or liquids into the nasal cavity. For example, nasal reflux. Delayed initiation of the pharyngeal swallow reflex, allowing materials to move deeper into the pharynx or larynx, thus increasing the risk of aspiration. And diminished tongue and pharyngeal muscle force to move the bolus through the pharynx, resulting in materials hanging in the throat. If you've ever had that happen to you, you know you'll do just about anything to get that bolus through the pharynx so that you can find some relief. Reduced laryngeal elevation and closure, making the airway more prone to entering materials. Inadequate opening of the circopharyngeus muscle, hindering the movement of the bolus into the esophagus and enabling the retention of food residuals within the pharynx. So there are lots of things to look at in the different phases. Then next, looking at underlying pathology or cause of what's going on. So dysphagia, just like in children, dysphagia is a secondary disorder, meaning that it results from another primary cause. Common causes are neurological damage due to stroke, brain injury, or a disease such as Parkinson's, and laryngeal damage due to radiation, surgical removal of the larynx, or trauma. Stroke is a leading cause of disability and death among adults. The percentage of those developing dysphagia following stroke is 50% or higher. And then looking at TBIs caused by car accidents, falls, and physical acts of violence, they can also result in diffuse brain damage, and 1/4 to 3/4 of individuals with TBI exhibit dysphagia. Progressive neurological disorders are disorders of the nervous system producing discoordination and weakness of motor skills, as well as decreased sensory abilities. And this can occur with Parkinson's disease, ALS, and dementia. Head and neck cancer treatments. Cancerous growths of the mouth, pharynx, and larynx are treated with surgery, radiation, and/or chemotherapy. Dysphagia is often present prior to medical treatment for these cancers, but it frequently becomes more severe following these interventions. Head and neck cancers often result in oral or pharyngeal stage dysphagia, which can be readily managed for many individuals. The severity of dysphagia can range from mild to severe. Penetration aspiration scale uses an 8-point scale to describe the degree of airway protection during the swallow. A score of 1 indicates that no material enters the airway, whereas a score of 8 indicates that material is aspirated and the individual shows no effort to cough and no gag reflex. A patient with a score of 8 is at very high risk for aspiration. A clinical swallowing exam will be conducted by an SLP. It's also referred to as a bedside swallow examination. Current and past medical records will be reviewed. A comprehensive client interview to learn medical, social, family history, and history of the swallowing problem will be conducted, looking at when the problem started and what foods are the most troublesome for the patient. And a thorough oral mechanism exam of the mouth and throat will be done to determine structural and functional adequacy for swallowing. Trial feedings or an observation of the client during a meal will take place, and feeding recommendations, if appropriate, will be made, and the client will be referred for instrumental assessment of swallowing if it's indicated. And then there'll be a referral for the client to other professionals for any other specialized testing that is needed. An instrumental dysphagia exam will be an evaluation of swallowing problems using technology or instrumentation typically providing a more objective and quantifiable measure of swallowing functions, including the safety of those functions. It'll be more involved than just the bedside swallow examination. This will include a fiber optic endoscopic examination. It's also known as FEES. And it provides direct visualization. Hold on. Direct visualization of the swallowing mechanism, and a fiber optic endoscope will be used, which is a flexible tube that contains a small camera. It'll be passed through the nose and into the pharynx, and it's going to yield a picture of the swallowing mechanism before and after the swallow. Ultrasonography or an ultrasound is technology that might be used for a dysphagia evaluation. High frequency sound waves are used to create black and white pictures of the structure. A transducer placed either at the chin or at the thyroid area at the front of the neck is going to generate sound waves. And then video fluoroscopy. It's also known as the modified barium swallow, or MBS. It's an instrumental approach that's most commonly used for swallowing evaluation. It's kind of like the gold standard that's used in most cases, and it's going to give you information on all phases of the swallow. Following assessment, the speech-language pathologist often provides direct treatment to remediate dysphagia using two types of rehabilitation strategies. Compensatory approaches and restorative techniques. And in compensatory approaches, strategies for a specific problem in order to make swallowing safer and more efficient will be used. For during meals, the SLP might place a mirror in front of clients who experience oral leakage of foods or who pack food so that they can monitor and correct the problem. Or the SLP might help clients with left facial weakness place food on the stronger right side of their mouth during the oral preparatory phase. Postural techniques will be used. Position in which the individual touches the chin to the front of the neck, while swallowing is helpful for reducing aspiration of thin liquids. Restorative techniques are intended to improve or restore swallow function. Examples might be some oral and pharyngeal exercises and biofeedback. Nutrition and dietary considerations will also be looked at, and the importance of this cannot be overestimated. Because dysphagia results from an underlying disease, individuals must achieve adequate nutrition to promote healing of and recovery from the underlying disease. For example, persons recovering from neurological injuries such as stroke or traumatic brain injury have greater nutritional needs than they did prior to their illness. And that is the end of the lecture for Chapter 15 and the end of the lecture series for this semester. Thanks for listening.